morning, everybody. This is Dr. Ashish Arbat. I thank Indian Arthroscopy Society for making this platform an educative platform, and I'm indebted to the members and all my colleagues, my friends, my seniors. I seek their blessings for carrying on the research work and the work that we all are doing, and all the best to all the IS members. Today, we are going to present a bone patella bone graft journey of our experience with the beta TCP screw and bone patella bone graft in athletes. The exact ACL injuries in the world are unknown. Considering alone the US and India, there are around 2 lakh ACL stone each year on an average, and around 1 lakh ACL reconstructions are done in the United States per year. There always has been a controversy in managing these injuries and how centers are divided in the choice of the graft for reconstruction and whether the surgery is needed. The insertion of the anterior cruciate ligament is just anterior to the anterior horn of the lateral meniscus. That's a bit medial, anterior medial, and it's 17 millimeters long and it is 9 millimeters wide, plus or minus 2 mm. The graft selection remains ultimately a surgeon choice and his experience. The research says that the graft should have a tensile load of more than 2,400 newtons and its stiffness should be more than 650 newtons per millimeter. The nearest that reach are the bone patella bone graft and the 4 standard hamstring grafts. It is desirable to begin with a graft with a stronger than the tissue to be replaced because there is a 50% loss of the graft strength after implantation, and that's a big point to be noted. The bone patella bone graft is around 8 to 10 mm depending on the size of the intercondylar notch and the height of the patient, and it is taken from the central third of the patella tendon with its adjacent patella and tibial bone blocks. This is how it is taken. There is a longer parallel pipe from the tibia and the shorter side from the patellar area. So vice versa, this area goes on the femoral side and this on the tibial side. The technique, it's an open technique or a minimally invasive technique for educative purpose and explanation purpose. This is the approach. We take a subcutaneous approach. We reflect the paratinum. Around 1 or 2 mm graft is measured on the bony area with a ruler. Desired blown plug is taken with a special saw and a blade which is less than 2 mm. Remaining part is taken in a tunnel fashion or a pyramid fashion with an osteotome, and rest of the graft is taken out with a scalpel from the soft tissue area. This area many surgeons prefer to close before proceeding to the procedure, but if the paratinum in the proximal area and the distal area is intact, posteriorly you can carry on without suturing, and later on the suturing can be done post-surgery. This is how the graft tunnel is placed. The femoral tunnel, the longer part, the shorter part in the tibial tunnel, and many modes of fixation. Here we are going to talk about Milagro Advance, a BPT PLLA combination screw which is specially designed and hardened and specially separated threads for graft growth, and the only screw that is recommended for bone patella bone interference fixation, but the ideal gold standard remains the titanium screw. The graft selection is worldwide divided, but cutting the long story short, the quadruple stranded graft, multiple bundle replacement graft may be better for approximate function to the pre-injury level. But remember, all our grafts that we use should have the tensile strength of combined 4,000 newtons, and this has to be the mainstay of the graft placement. Again, the size of the graft should be more than 8.5 millimeters. That is, a lot of papers have been reported that a graft size less than 8 millimeters are having a huge incidence of re-tear. So whether you choose the 4 stranded or the bone patella bone remains your choice, but the graft has to be an alternative replacement graft with a good tensile strength, and the revision surgery should be avoided. The graft placement, there are practical implications where if you place it too anteriorly, the capturing of the knee becomes very tight in the flexion and stretching. So the ideal placement is posterior lateral in the semi-horizontal position. It should not be too anterior or too posterior or too inferior, because if the graft gets taut in extension and gets loose in flexion, again that is not advised, and it should not stretch out also. So the location a bit posterior and at the ridge of the AM and PL bundle of the ACL is the ideal placement. So this is a video. Here we have taken a 11 bone patella bone graft in the shown fashion. It's an athlete. The player plays is a bowler in cricket, and he requires a stiff graft and a good knee for the future actions. So this is, we have cleaned up the area of the intercondylar ridge. We have placed a tibial bead pin, and in this particular fashion, we check the bony ridge that separates the AM and PL bundle, and you have to place it at the center of this so that you can recreate the AM and PL bundle virtually. We've taken a transportal approach and drilled with a special refined bead pin with measurements. If you don't have, you can use a regular bead pin, and then the desired depth is achieved, and we have taken the measuring stick and measured the depth so that we can place the graft in the desired area, drilling according to the depth, and after that we should see the congruency of both the tunnels. They should be congruent and there should be no graft issues. We relay it with a loop, and this is how it is taken in the femoral area from the tibial area. You can take it either ways, from the portal or from the tunnel. This is the placement. The bony part goes up, and this is a nice and thick graft. Now remember, we have to increase the diameter of the head for the head of the screw at the face of the graft placement tunnel. So what we do is we increase the diameter with a special designed instrument that increases the diameter to the desired size of the graft head. Mind you, without this, the screw would break. And then we are using the Milagro Advance screw to fix the femoral end and the tibial end likewise. And how much should it fix? It should be stiff. It should go in with a squeezing movement, and just at the tip of the graft, the screw should be snugly fitting so that it is not too in or not too out, and that is what gives a good fixation. So where are we now in 2020? This is a meta-analysis of CORR. It favors that measures the forehamstring graft has been shown to have knee pain in the later days, where bone patella bone has proved to be a better choice in athletes. The failure rate and the fixation, there are a lot of papers, but again, study by debut, the selection criteria comes from multi-center, bioobservable versus metallic screw, which is the focus of this presentation. There has to be the results. There is a very low evidence of difference, but if the screw is a beta TCP, PLLA better combination, the results are better, and it prevents all the issues of metallurgy, interference screw issues of a metal screw, and removal of it or any other issues of post-injury. So we recommend use of uh, Milagro Advanced kind of a bioabsorbable screw with a beta TCP and a PLLA combination, where beta TCP is more over the PLLA, and the fixation is good, and it should have a longer placed, mind you, the threads, so that the graft goes in between. The paradoxical tunnel enlargement with only beta TCP screws and the metal screws are a big area of discussion, and the latest papers show that if it's the right combination and the screws which are having more of the beta TCP and PLLA combination 60 to 40%, there is a very less incidence of paradoxical tunnel enlargement. So the beta TCP screw with an aperture fixation should be a reduced tunnel enlargement in the vicinity of the screw. So that is very important, and you should understand that even during use of the soft tissue graft, you should use the interference screw with an adequate length of the graft so that loosening doesn't happen at that area. So associated risk factors with revisions. It's a study from Kaiser Permanent. Again, the soft tissue grafts are shown to have a higher incidence of revision. Again, the functional outcome after metallic and bioabsorbable screws, if it's a use of a right screw, there are no differences found at over a year and return back to sports. The long-term outcomes of ACL reconstruction with patellar tendon, it shows that the graft laxity and osteoarthritis are a bit higher with bone patella bone, but when the patient comes in grade 2, but in acute injuries, the bone patella bone tendon graft has been shown very high rigidity and fixation in compared to the statistical need of amount of force or the newtons per millimeter. So the bone patella bone graft is a better choice for most of the athletes. Thank you, and it's been a pleasure to talk to all the IAS subscribers. And again, we'll be coming with such studies on our bone patella bone and preferred choices of grafts. The latest papers say that point one, if there is a meniscal injury, the amount of osteoarthritis seen over 5 years to 15 years is very high. So it should be done in an early stage before grade 2 OAs changes. Secondly, four hamstring graft and bone patella bone are the surgeon's choices 50-50% in the world. Thank you, and